I have a central message to deliver in this talk. The central message is every one of us involved in medicine, or involved in ENT in particular, have a duty, whether he's an academic or whether he is a surgeon, administrator, running a department, running a hospital, to grasp at least a working knowledge of the research methods, and statistics is a part of the research methods. This is the central message, and I'm going to illustrate by two points why this central message is crucial. If we work within environment that requires evidence, we need to generate evidence by doing research. But even those who are not involved actively in generating evidence would at least need to know how to analyze it and how to get an understanding from it. So let me start with this. Imagine you have a cube with 6 different faces. These are the different broad fields of research in general. One of them is causation, how this developed, the etiology. The other is screening, the prevalence and the incidence. The third is how to diagnose. The fourth is the treatment options available. The fifth, the prognosis, how would it develop further? And the sixth, the basic sciences involved in measurement and in electron microscopy and things of this sort. So we start with the first, the causation. Let's take the example of COVID-19 because it's so active at the moment. If causation is about finding the harmful agent that started a certain disorder or a disease. And this is how smoking was related, for example, to cancer larynx or cancer chest, or obesity was linked to myocardial infarction. And the same happens for COVID-19 as well. It may start with a case report. Someone will see something of interest, something that's odd enough. A pharmacist in the United States noticed a lot of cases requiring certain antibiotics for Pneumocystis carini. And then this led to the discovery of the AIDS and the HIV. A colleague of us, an ENT doctor in China, have also seen a lot of a string of cases with a very atypical type of pneumonia that have a lethal outcome. And this started the acknowledgement that there is a pandemic that was called COVID. So even a case report, even just writing down your observation and publishing it is useful. But of course, if you want to identify that this particular harmful agent is the cause of this particular disorder, you would need something more elaborate. You could look backwards and do a case control study, as you will see later, or you could look forward and do a cohort and follow up groups to see if a certain harmful agent would cause the disorder in relation to others. The other face of the cube would be screening. I mean, we're very interested now in knowing the daily incidence of the COVID-19 worldwide. If you want to know the prevalence of hearing loss among school children or among workers in a factory, or the blood pressure in a certain group, then screening by doing cross-sectional studies is the way forward. This is of importance, of course, to know how many are involved in a certain disorder, because this is how you are going to allocate resources. And of course, if you identify people with a certain pre-symptomatic disorder, you will be in a better position to treat them properly. Now, the third phase of this would be the diagnosis. And what we usually do is, say in COVID-19, you have a gold standard like the PCR. It's not good enough. PCRs has got only a sensitivity of around 70% something. So it misses about a third of the cases. But if you want to propose another diagnostic factor, it's got to be related, compared to this gold standard, by a cross-sectional study. You could, for example, try to see the rapid immunoglobulin test, or a plain X-ray chest, or a CT scan of the chest, and compare the results you obtain from this to the gold standard, which is the PCR. And of course, treatment is the fourth of this. When this started, we didn't have any clue about how to treat it. So they started treatment with things like the anti-HIV or anti-malaria or anti-Ebola, and of course steroids at one point, and things like this. And that started with case series. Someone has just started to use the anti-malaria treatment or a case control or even a small cohort. But it's only when a randomized controlled trial was started in a very strict and a very open rules, and some of them are very big, like the recovery or the solidarity trials, that concrete evidence started to develop about the treatment. So even though you could start a trial about treatment with a case series or a case control, the idea is to do a randomized control trial. Sorry, it's not working for some reason. Now, the fifth phase is the prognosis. Say, for example, now we know that anosmia is one of the recognized complications of the COVID. What's going to happen to these patients who lost their sense of smell? Are they going to regain it in full or regain it partially, and when, in 3 weeks or 3 months or never? This is what you can study this by doing a cohort. You identify a certain group of patients with the condition and follow them up forward in time. And this would bring about enough information so that you could advise patients after this, if they have anosmia, that look, the chances are, say, 70% or 80% or partial recovery after so and so time. And the last phase of the whole story is the basic sciences, like the RNA structure of the COVID-19, like exploring different technologies or having different ways of imaging. The virus has an electron microscopy image. The receptors were identified. This is the basic sciences behind the research, and it fills up a very important gap in our knowledge. So basically, this is the cube with the 6 faces, that if you are facing a question or an observation, you can think about it in terms of this, which face of the tube you would actually want to pursue to get some results. Now, you can do research in 2 ways. Primary research is when you collect your own data. But secondary research is a field of extreme importance. And in fact, meta-analysis, one of the forms of the secondary research, would be the top of the hierarchy of evidence. This is the best possible evidence you could obtain, is a secondary research. You don't get the primary data yourself, but you generate data by reviewing data produced by others, and from it you could find out a suitable answer. Of course, you can do a non-systematic reviews. Most of our knowledge is obtained from textbook chapters, which are basically a non-systematic review. You could summarize, an expert usually would summarize results from primary studies. But if you want to do it as a systematic review rather than a non-systematic, then you put on a plan, a strict protocol about a certain time window. I'm going to review all the English language literature between year so and year so, and with such and such inclusion criteria and such and such exclusion criteria. And then your findings will carry on more weight. But it's meta-analysis which is really of utmost interest here, and this is when you take data from different studies to answer a question yourself. It may be that the data produced so far lacks the power because the disease is not very common, or you don't have a large sample. So never the treatment efficacy was never proved, for example. But if you combined all these articles, all these data together from different sources, you may obtain enough power to get a significant result. Or it may be that the data or the evidence is conflicting. Some would say steroids and herpes zoster oticus is useful. Some would say no. By again, combining the data from different sources would get you into closer to the answer. It produced something like this. If you go through it, this is a comparison between a radical neck dissection, which is what was the gold standard at one point for treatment of metastatic squamous cell carcinoma in the neck, combined with a modified radical neck dissection, which is a more conservative and functional operation. And as you can see, there are 7 different studies here. Some of them are very small in number, like the first one is very few, like something like 33 patients or so that contributed into this. Now, what you want to do is you can obtain 4 numbers out of this. And the 4 numbers, sorry, I got this. Here we are. You compare the results you obtain from the new treatment, the modified radical, to the results you obtain from the standard treatment, and you calculate the odds of the treatment, and then you plot a line with the well, its center is here, with the odds ratio, and it favors the modified radical neck dissection. And the spread here is the confidence intervals. And as you can see, if the spread is wide enough and it crosses the point of no difference, then this study in particular would not bring about a conclusive evidence because it crosses the line of no difference. And of course, the study was done only on 30-something. So at the end of the day, it was given a very small weight. It was given 2.5% of the whole weight. Compare this to the third study, which was done on more than 1,200 patients. That carries much more weight than the first study. And the confidence intervals of the third study is much narrower than the confidence intervals of the first study. Almost there. And it actually favors the neck dissection rather than the modified radical neck dissection. But because of the number of the participants and because of the good study design that ended up with a very narrow confidence intervals, it was given a very high weight. Almost 50% of the weight of the whole study was given to a single study. At the end of the day, you'll be left out with this. This is the final outcome, a rhomboid-shaped thing that actually lies almost exactly on the line of no difference. Why? Because the odds ratio is 1 point. If the odds ratio is 1, that means that the odds of doing a modified radical neck dissection is similar to the odds of doing a neck dissection. There is no difference. If it is 1.06, it's still not significant. But the confidence intervals here is fairly narrow. But this, because the final outcome was lying on the line of no difference, then you can conclude with some more power that there isn't much difference in the outcome in terms of survival between modified radical neck dissection and a neck dissection. Here, you've not actually obtained the figures yourself, you use figures obtained from other sources. And then the final thing about secondary research is that you can use the information you generate, the evidence you generate, either from the primary or the secondary, to do other things, more elaborate things like decision analysis, for example. If you want to generate a probability tree with all the with the outcome of a certain path compared to the other, and you add up all the other complications and the costs and the duration of the treatment, then you use the information gained from several studies to do this. And of course, you put on as well some economic analysis, because some treatment like radiotherapy could take longer than surgery, but the costs will be different. And you end up with either guidelines, you can generate a guidelines, or even a protocol if you have more evidence, or a statement of position if there's just a consensus, or a statement of position if you don't have enough evidence to be very dogmatic about it. So that was my first point, that as a working knowledge of the research methodology with statistics as a part of it is how we get into evidence. Either you do it primarily with even a case report, any phase of the 6 phase cubes would get you into some can be very interesting sort of data, as the discovery of COVID or the discovery of HIV. Even if you cannot do your own research, you could still be useful by generating evidence from research done by others. You can just collect on data on a certain subject and start a meta-analysis. Now, I try to make my second point, and my second point is, even if you are not going to generate evidence, you still need a sound knowledge of research methodology and statistics in order to understand the evidence produced by others. And I start with this example about treatment options. You've got 6 options here. If you spend a second to go through them, to see option A is proclaiming that it reduces the death risk to only 18%. Option B would reduce the relative risk to 35%. Option C would reduce the absolute risk to 9.9%. The odds ratios can be reduced to 59% by option D. Option E increases the survival from 70-something to 80-something. And the final option would tell you that if you choose option F, 10 more patients, you need 10 patients to save 1 extra patient life. So these are the 6 different ways of putting on treatment, but let's analyze the figures. I'll take you quickly through this. The core thing is the 4 figures on the top here, on the top left. You've got a standard treatment of, say, in a cancer, some form of cancer treatment. Again, it's a new proposed treatment. When you use the standard treatment and 46 patients, 13 of them died and 33 survived. When you use the new treatment, 7 died and 31 survived. And from these simple 4 figures, you could generate a lot. You could generate this 9 different indices very quickly. You can use only a calculator to do this. Of course, you can use a computer. You can calculate the death risk. The standard treatment, 13 died out of 46. And that was equal to 28% or something. And the same can apply to the new treatment. You could compute the odds of dying this time. You compare the number died against the number survived, and you produce these 2 figures. You could calculate the relative death, risk of death by dividing the death risk and the new treatment against the death risk of the standard treatment. You could also get the relative risk reduction by if the relative risk of death is about 65%, then you've reduced the death risk by 65% to 65%, then the risk reduction is the remaining part of the 100%, which is 35%. The absolute risk reduction is something you could calculate easily by subtracting this time rather than dividing the death rate from one form to the other. And then when you get something like 99% absolute risk reduction, the numbers needed to treat is the reciprocal of this. You divide 1 by 9.9 and you obtain something like 10 patients. And finally, you calculate the odds ratio of death from one form to the other, and that brings you to 0.23 with certain confidence intervals. So this is how to analyze a very simple. Of course, it can get much more complicated because here the outcome is only binary. It's either died or survived, whereas the outcome can be a continuous thing like different blood pressures or different hearing levels. And also the standard treatment is compared to a new treatment as separate categories. They can also have various forms. But you end up with this. You end up with a sheet that gives you all the indices, and you have probably already guessed this. All the different options were actually one and the same. They were just coming out from the same study, but a different way of reporting them can give you a very different impression. The death risk remains the same for the new treatment, 18 points. The relative death risk is you've reduced the death risk to about 2/3, and the relative risk reduction is therefore 1/3 of it. But look at this, the odds ratio, so it is reduced. It has a very wide confidence interval. It's almost 8 times between the lower limit and the upper limit, between 0.2 to 1.6. When this happens, when the confidence intervals crosses the line of no difference, as you have seen in the meta-analysis, it tells you that you cannot be 100%. You cannot be sure that the results are significant in any way. The confidence intervals would tell you that the 95% of the times any way between 0.2 to 1.6, you could find the real value. But if the real value crosses the line of no difference, and it's 1 if you are looking for an odd ratio, and it is 0 if you are looking for a mean difference, then you know that this result is not significant. Sorry, I've done it again. Anyway, but so all the other options were just coming from one study with different forms. Here is another study that was done 20 years ago in Edinburgh about finding a way to treat the T2 tongue-based carcinoma, because surgery used to bring about 38% of the patients would die if they had this operation. But the operation, of course, have a very high morbidity and functional problems because of the surgery of the base of the tongue and aspiration and the speech and all this. And there was a proposition that you don't have to do the surgery. You could irradiate the base of the tongue and do only a neck dissection for the metastasis. And that brings about a reduced treatment success to 33% rather than 38%. Again, if you look, the standard surgery has an advantage. But if you just say that the surgery, that those who had the surgery versus the radiotherapy had a 5% improved chance of survival, you are actually giving the wrong impression. Because again, the confidence intervals here crosses the 0 line between 0.12 and 12. And you cannot be sure whether it's actually 12% more or actually less than the success rate of the surgery. The other thing is, think about it. If you need, the numbers needed to treat for this group was 24 patients. And we see about 4 or 5 patients a year with T2 squamous cell carcinoma of the base of the tongue. That means that in order to gain 1 extra survival, you would need to subject all these patients to a very difficult operation with very high complication rate. And you need to spend about 4 or 5 years because you could save 1 extra life. And of course, the choice at the end of the day is for the surgeon and the patient, but you need evidence to back this, to explain to the patient in order to achieve a good decision. So that's one example about how important it is to understand the real meaning of the evidence in treatment. And I'll give you one further example about the importance of interpreting the results in a diagnosis. To interpret the results of a diagnostic test, you would need to go through a dozen of different things, like the 8 different indices on the left and the 4 on the right. You need a knowledge of the sensitivity, specificity, all these things. I'll give you 3 very quick tests. And let's go through this. This is test number 1, which is rather specific test. Again, you have 100 patients here. 5 of them had the disorder and 95 were normal. And then you apply test 1 and you get positive results in 6 patients and you get negative results in 94 patients. And quickly you could get from the ratio of the true positive to the total who got the disorder. The sensitivity here is rather low. It's 0.2, like 20%. But if you look about the numbers of the true negative, this is 90 out of 94 tests you've done and out of 95 patients who are normal. So it is very specific. In fact, the specificity here is almost 95%. But would you take this test? It's specific, but it's not sensitive at all. Take this one step further. We've only looked into the vertical columns so far. Look into the horizontal columns now. The positive prediction value of the tests. You've done the test in 6 cases. 1 of them really was true, and the other 5 was false. So the positive prediction value of this is about 16.6, fixed, yeah. And the same applies to the negative prediction value. We had 94 negative results of the test. Out of them, 90 was actually true negative. So it has a quite high negative prediction value. It's 95. But take it even more 1 step further. if I get a test like COVID, for example, and you get a positive result, what does that mean? Does it mean you have got the disease or not? This is the likelihood ratio. Even with a positive result, you have a chance here that you can be normal. The chance here is quite high. It's about 5 out of the 1. So if you compare the probability of the true positive to the false positive, the probability includes relating them to the total of the normals and total of the disorders, you get a result here which is just more than 4. Ideally, the likelihood ratio of a test, a positive likelihood ratio, should be more than 10. That means that if you got a positive result, you've got a chance of 9 out of 10 that you have the disease is meaningful, not 1. And the other way around is when you look into the negative likelihood ratio, and this time you are actually comparing the probability of the true negative to the false negative, and you have for 0. You got 0 point something, 0.8 in here. Ideally, this should be a 10th, like 0.1. Now, if you want one single indices of how this test is working, you need this, the last square, the diagnostic odd ratio, and you obtain it by dividing the likelihood ratio positive against the likelihood ratio negative, and the result here is just 4 point. Now, remember, if this is supposed to be, if the likelihood ratio positive should be about 10 and the likelihood negative should be less than 0.1, then the diagnostic odd ratio could be anything up to infinity, but usually something towards 100 is fine, and this is 4. So this is a specific test, but it's not good. It's not good enough. Now, take it the other way, you can get a test with more sensitivity here, like you could test 2, diagnosed 4 of the 5 patients who had the disease, but it also had a high incidence of false positive cases. And when you look into the indices, you will find that its sensitivity is 80%, but it's not a very good specific test because this dropped to 60 something or so. And you could generate all the indices again, but you end up with the diagnostic odd ratio here is again 6 point something. That's not good enough. But the third test is good. It can produce, if you have sensitivity in more than 80 and specificity more than 80%, then you could expect a good outcome at the end. And this 1475 here for diagnostic odd ratio, which is not bad at all. So again, this is a working knowledge about how to produce these figures and how to interpret it. It's useful if you want to reach the proper diagnosis at the end. But that's not the end of the story. The tests can be good in obtaining an outcome compared to other tests. There are other aspects. There is the validity, for example, the internal validity, which is have everything been taken to reduce bias and the experiment to produce this test, or the external validity, could you actually generalize the results of your study? And of course, the construct validity, is it actually meant, this test you are advocating, was it actually meant to measure what it was supposed to measure? It's all too easy to say that with things like weight or height or things, because it's construct validity is obvious. But it's not easy when you are using questionnaires to measure things like happiness or IQs and things like this. Does it actually measure what's supposed to measure is another aspect. And of course, the accuracy and how accurate is a test. Now, if the test is accurate, then the results would be centered, would aggregate around the center, would aggregate where it's supposed to aggregate. If they don't, like in here, then you don't have a precise test. But if you have the results collecting into one corner, it's not into the center, but it's a good repeatability of the test, then this is good precision here, but it's not accurate enough. You need to calibrate it. Say for a Putin audiogram, for example, it may produce a repeatable results, but 5 or 10 decibels above or below the expected level. You need to calibrate it. And finally, don't forget that if the confidence intervals crosses, like in this example here, the confidence interval overlap, then this is the results may be doubtful. But if they don't, like the other studies, then you can be sure that the result, the center here is quite different from the other center at the end. And this is how we use the same concept of the odds ratio, the center, and the confidence intervals to integrate an effect size into a meta-analysis, for example. Now, I hope I have made my point that it's so important that you have a working knowledge, and a working knowledge can be obtained by maybe a good course over a week or so, something like 30 or 40 good lectures would give you all what you need to start the game. This is like learning chess. You need the steps are few, the rules are few, but you can play a very powerful game, or you can waste it by not following it well. By this I end, and I thank you very much for your attention.